morning everyone. So today we'll be looking at a critical appraisal of a decision analysis. So just again to reiterate about decision analysis. So it is basically a study where you do modeling based off different decision algorithms. Like one of them is a decision tree. The probabilities are added to the decision tree, and it is mainly analysis which is done. No, we don't recruit patients as such, but we go through literature to look for any the highest quality evidence available to put in our numbers as we had shown. So this is an example of a decision tree where this is a decision tree for whether or not to test for latent TB. And we can see they've considered many different possibilities. All the possible outcomes have been considered, and of testing also, if it's positive, then if it's a true positive, false positive, whether it's whether based on that do you treat, do you not treat, based on the treatment are there complications. So a lot of complications, a lot of possibilities have been considered, and we'll go to the rest also. So, and the different nodes also you can see the square node which shows a decision, the circle node which shows a chance, and the triangle show a terminal node. And this M shows a Markov model for TB. So TB patients can either have active TB or they can become TB free or cured from TB. It shows the different disease states. So again, the simplified version of that previous chart. So here we can see that the numbers have been put. So again, like what Sir was saying earlier, so the utility score, U stands for utility, and they've put 1 for survival and 0 for deaths. And the P's are the probabilities. So the probabilities are all taken from literature, and wherever they've assumed probability, they've mentioned also. So these probabilities we actually calculate back, we fold back, it's called folding back, and based on that we decide which arm is better. So here again you see the probabilities are calculated, then we sum the probabilities and keep folding back. So we here 0.1 into 0.9 plus 0 into 0.01, that comes to 0.99. Then we fold back here, it will be 0.882 into 0.99 plus 0.8918 and 0.082, and that will come to this node, and that is the total here, and that we keep folding back until we come to the total probabilities for each arm at the decision tree. So here we can see that the total probability is 0.9992 versus 0.99, so it's almost the same on both arms. So coming to the article for the study for critical appraisal today. So the scenario is that you've been given a responsibility of starting a tuberculosis screening program in patients living with HIV and AIDS as part of the NACO protocols. So WHO guidelines use a screening tool comprising of 4 symptoms to screen for the PLHA with TB. It is cheap and can be done by anyone, but the results vary from patient to patient. Also, there are some people who say that it aggravates the stigma related with TB. So you want to see if there's any other screening tool that can be used. So we do a search in literature, and we see the latest Lancet has this screening tool which can be used. So they've advised the use of CRP. They've actually looked at different things, but mainly CRP along with the W4SS screening tool. So this study is actually a cross-sectional study from a single community health center in South Africa. All patients who were in that center planned to start on ATT were recruited. So about 897 patients were recruited. This is just briefly to show what all has been done in the trial. So for all patients, blood has been checked for CRP. Sputum has been done where the expert ultra, and also cultures have been done, and urine also has been expert, and LAM also has been done. So now this is briefly what is done, and based on the information they got from this cross-sectional study, they have tried to make a decision analysis. So going into the critical appraisal part. So the first section we deal with we'll see if the results are valid. So the main questions here are there. There are mainly 4 important questions. We'll be going to them one by one. So the first main question is, were all of the realistic clinical strategies compared? So here in the study, they've actually compared four main algorithms for triage of a patient with TB. So patient with HIV. So if a patient comes with HIV, they would initially be triaged with these two tests, and based on this, a confirmatory test actually needs to be done. But they've only considered that the four algorithms for the triage test. So based on the four algorithms, the main four algorithms were the triage is positive based on the symptoms and CRP if either the symptoms score or the CRP at the level of 10, CRP with a cutoff of 10 is positive, or if the second option is if the symptom score or the CRP at the cutoff of 5 is positive. Then the third possibility algorithm they considered was if the symptom score was positive, after that if the symptom score was positive, CRP was done and the cutoff was taken as 10. And the fourth is again if the symptom score, if only the symptom score was positive, in series a CRP was done, and if that is positive, then further evaluation was done. So out of which ideally they should have also looked at the confirmatory test, which they've not included in their analysis. So not all of the realistic clinical strategies were compared, but all clinically relevant outcomes were considered. So this is a study, they've looked at mainly sensitivity and specificities of the different tests. Overall clinically relevant outcomes like mortality, morbidity has not been considered. Cost of interventions, quality of life also has not been considered. Was an explicit and sensible process used to identify and select and combine the evidence into probabilities. So what they've done is they've generated the data from their cross-sectional analysis, and they've combined it into sensitivities and specificities, and based on that they've come to the appropriate sensitivities and specificities for the four algorithms mentioned there. So that has been done adequately. Were the utilities obtained in an explicit and sensible way from credible sources? The only outcomes which are considered were sensitivity and specificity. So this again was done from within the trial itself. There were no other utilities which were considered. So based after this, the trial, the validity of the study is it's acceptable. So we will see the results. So in the baseline analysis, these are the three questions related to the results. So one is we see whether there is one algorithm has any benefit compared to the other one. Then we look at the evidence use, strength of the evidence used in analysis, and we look at the uncertainty in the analysis. So first, to see if one strategy is better than the other, or are all the strategies the same. So here we can see these are the four algorithms, and algorithm 1 was with the symptom score positive or the CRP positive. Algorithm CRP positive at 10. 2 was with the symptom score positive and CRP positive at 5. Algorithm 3 was if the symptom score was positive and in series. After the symptom score was positive, they would look for a CRP positive at a cutoff of 10. And algorithm 4 is symptom score positive and in series CRP cutoff of 5. So here we can see that we are looking at mainly the all participants. We can see that the highest, because we want to use this as a triage test, we would like to have a highly sensitive test so that we can rule out patients who don't have the disease. So here we can see, we look at the sensitivity mainly. So the highest sensitivity is in the algorithm 2 as compared to the other tests. The same algorithm has of the lot the lowest specificity, however. But because we are looking at a triage test, we look at the one with the best sensitivity. So again here, this is just comparing the different sensitivities. Here compared to the questionnaire, the 4-symptom questionnaire, the second algorithm has a higher sensitivity by around 10. But compared to the 4-symptom questionnaire, the specificity comes down. So we, based on the results, there is about 10% increase in the sensitivity. So how strong is the evidence used in this analysis? From this, the evidence used in this analysis is from the same cross section. The large sample size makes the evidence believable, but it's from a single center, so it may not be applicable to other places. Then better evidence could have also been used. could the uncertainty in the evidence change the results? In this study, the only uncertainty is the confidence intervals of the sensitivities and specificities calculated. So here also we see for the symptom score which they use, the sensitivity range is from 68 to 85. If we look at the algorithm 2, which is the one we thought was the best, the sensitivity, the confidence intervals are between 84 and 96. So here there is a mild overlap. So if you repeat the study, in some cases actually the algorithm 2 also may be equal to or slightly less than the symptom score study which is done. So going on to the third part of this analysis. So the third part is, will the results help in our patients? So for this, two main questions we ask are, do the probability estimates fit my patient's clinical features, and do the utilities reflect how my patients would value the outcomes of the decision? So that is ideally in the decision tree we had discussed in the beginning, those probabilities which were assumed and the probabilities we got from data, we need to see if it compares to our patient's clinical features. So, however, in this study, probability estimates were not used. They had used the data from their own study. So we can just look at the baseline characteristics and compare it with our study also. So this is mainly patients around the age of 32 with the average CD4 of median CD4 of 299. Comparing it with Indian data, again the average age is slightly higher. The median CD4 also is slightly on the lower, around 70 difference, 60 to 70 difference is there. So do the utilities reflect how my patients would value the outcomes of the decision? So the utilities here which we consider are sensitivity and specificity, which don't really, it's not something which patients understand. So the answer for this will be no. So summarizing this study based on data from a prospective cross-sectional study on patients with HIV from a single center in South Africa, showed that a strategy using both the symptom screening tool and CRP is highly sensitive in using as a triage screening for patients with TB, HIV and TB. The positives of the study is that the study had a large sample size, but however it is from a single center, and as a decision analysis study, it did not consider all the possibilities and was lacking in clinical and patient important outcomes. So coming to our clinical scenario, would you use this tool for screening for the NACO recommendations? Based on this study, I would not change practice. Thank you.
Thank you, Thomas. Any questions? So just to briefly summarize what Thomas has said. So what they have tried to look at is, okay, symptom score is nothing but, okay, somebody comes with fever, cough, expectoration, hemoptysis. So that is the patient population whom we are encountering. And what are we going to do about them now? What do we do in routine clinical practice now? Someone presents with fever, cough, expectoration, 14 days. What will you do next? Chest X-ray, sputum AFP. Okay, we'll take one of those. What is the standard? Okay, we'll do sputum AFPs. But here, what are they looking at? Instead of doing that, let us do a CRP and have a cutoff of 5. They have assumed multiple other algorithms. Just for simplification, I am just writing one of those. And then, depending on that, there is a possibility that some of them will have CRP of more than 5 and some of them will have CRP less than 5. And among those, some of them will really have TB, some of them will not have TB. Similarly, in this group, you do sputum AFBs, some of them will have positive, some of them will have negative. And among those, some of them will really have TB. There is a small possibility that they may actually not have TB, may be a false positive result. Similarly, among those with negative results, we get a number. Among those, even if those sputum AFB was negative, some of them may actually have positive TB, and some of them may have will be negative. So far we have arrived at a decision. Now what do we do further? Once we diagnose PV, we treat. And after treating, some of them may get cured, some of them may not get cured. And out of those cured also, some of them may develop side effects, no side effects. Same thing will happen in the no cure arm as well. Among those who have not been diagnosed with PV, you will not treat them, but later on they may develop PV, or they may have been confirmed to have PV, or they may continue to remain asymptomatic, or they may get resolved or cured. So those are the other possible arms here. So if we need to look at the decision analysis till the end, it goes on till here, and then you look at the utility scores, whether cure you can take it as 1 and no cure you can take it as 0. That is one assumption of a utility score. Or some of them may disagree. No cure is not there, so why are you taking utility score as 0? Okay, then we have a discussion. Okay, let's see, say cure, if we assume it as 1, let's assume no cure as 0.2. That's based on consensus or expert opinion. So a group of experts will have to sit down and look at that. So in this scenario, what they have done is, they have stopped it here. So based on this analysis alone, you have true positive and false positive rates, based on which you can calculate sensitivity and specificity. So that is the answer that we get up till here. So they have told that by using this particular arm, you get a sensitivity of 90%, and by using this conventional arm, you get a sensitivity of 70%. So that is what they are trying to project here. So we will not be able to get the net benefit of what we are going to get by using this algorithm, but we get some information about what is the sensitivity of using the symptom score plus CRP versus using the symptom score alone. So for this net benefit of 20% of sensitivity, will we change our practice to using CRP? What do you think? Akash? You get a net benefit of 20% of sensitivity. What is sensitivity? A highly sensitive test will help us to rule in a disease or rule out a disease. Rule out a disease. So if a highly sensitive test, if it is going to be negative, it will help you in ruling out the disease. So there is a reasonably better sensitivity test. So you will be able to effectively rule out a significant number of diseases. But the difference is about 20%. So you gain another 20% of patients. You will probably not require to do the next step of doing sputum AFPs, meaning you will not need to go further by doing this arm. That is the net benefit. But whether it will translate it into patient related outcomes or not is probably not answered by this particular decision analysis. So what we can do is, we can extrapolate it till there. We can use this study data for this probability arm, look at other literature and fill up all the other probabilities, and then work out for ourselves to see what is the net utility score, net quality gain or median survival gain or the cost benefit, and then we can arrive at a decision. Because CRP is not coming at 0 cost. In fact, sputum AFP is probably cheaper than CRP. Why are we going to invest some more to get this 20% of sensitivity benefit? Those are the considerations that we have to have. But we will get an accurate value of the net cost benefit if we extend the decision tree till the end.